Hi, everyone, and welcome to Dementia 101. Okay, let me tell you a little bit about how I expect for today's program to go. As I've mentioned, all of you have been muted. In the event that you find that you're unmuted or that your video has started, please go ahead and turn off both your audio and your video, just because it could be a bit distracting to have the audio or the video going. I want to point out a couple of features of the Zoom technology for anyone that isn't familiar with it. I am going to be pausing a couple of times during the program here this afternoon to take any questions that you have as we go along. What I'd like you to do is find the chat feature, which you'll find in the menu, which is either up at the top or the bottom of your screen. Go ahead, click chat, and you should see a box pop up that says Zoom group chat. It looks like this. And if you type a message in that box, your message is going to go to me privately. So I will be keeping an eye on questions as they are coming in. And as I said, I'll be pausing a few times throughout. I may skip over some questions if I know that it's a question that's going to be answered later in the program. But I will try to answer all of the questions that I can during our time here. I have a request to increase the volume. I am not able to increase the volume on my end of the recording, so please adjust the recording on your computer's settings. Okay. This program is being recorded, but none of your names, video, or any of our chat is visible. It is just a voice-over recording of these slides, and we will be making a recording of this program available on our website in the next few days. If you would like to receive a PDF copy of the slides that I'm speaking from this afternoon, please go ahead and send an email to education@alzsd.org, and I'll remind you about that again at the end of the program. So before I get started, I just want to thank you in advance for your patience with any technical difficulties that we may have here today. As you're probably aware, this is our first online education program at Alzheimer San Diego. I am working remotely, as are all of my Alzheimer's San Diego colleagues. And so what that means is A, I'm using a new platform, and B, I don't have any technical support here. It's just me, and this webinar. Technically, I've got this girl here with me, but frankly, she's not really all that helpful. So I would really appreciate if you are having problems, please don't get frustrated. This recording is going to be made available to all of you, and our staff is available at Alzheimer's San Diego to answer questions and make sure that you get what you need. So thanks in advance for your patience with this process. So I'm Amy Abrams. I'm the Director of Education with Alzheimer's San Diego. We are a local nonprofit organization that's headquartered in the Kearny Mesa area of San Diego, and we do serve all of San Diego County. Our mission is helping families today while we support efforts to find a cure for tomorrow. So here is our agenda for today. I'm going to be talking about the various causes of memory loss and cognitive changes, including Alzheimer's disease and other types of dementia. We'll talk about the common symptoms of dementia and how they differ from normal age-related changes. We'll review risk factors, screening, and methods for getting a diagnosis. I'll be describing the general stages of dementia and what to expect as the disease progresses. We'll talk about symptom management strategies. That's medications, environmental modifications, and behavioral strategies that might help. And we'll review some things to be thinking about for the future. to provide for the safety, well-being, and support for the person who's living with dementia and those who care about them. So let's start by talking about the various conditions that cause memory loss and other cognitive changes. The vocabulary of dementia can be somewhat confusing, so I want to start by clarifying a couple of these terms. Mild cognitive impairment, or MCI, is sometimes referred to as minor neurocognitive disorder. So a person may receive a diagnosis of mild cognitive impairment when they've undergone some testing and it's demonstrated that they've got some memory or cognitive changes that are not severe enough to interfere with their daily function, but that are more significant than normal age-related changes. So this is a separate diagnosis. This is a different diagnosis from Alzheimer's or other forms of dementia. Dementia is sometimes referred to as major neurocognitive disorder. And dementia is defined as a group of symptoms that are caused by an underlying medical condition that cause difficulty with memory, language, visual perception, problem solving, and attention. Dementia is not one specific thing. It's a syndrome, and there are many dozens of different medical conditions that cause the symptoms that we refer to as dementia. So, Alzheimer's disease is the most common of those medical conditions. It's an irreversible progressive brain disorder that we'll be talking about in some more detail here in a moment. We use the term young onset to describe those forms of dementia whose symptoms appear in younger adults, meaning those who are in their early mid-60s, 50s, 40s, and sometimes as young as the 30s. Young onset forms of dementia account for between 5 and 10% or so of all cases of dementia. It's important to remember that not all symptoms are caused by progressive medical conditions like Alzheimer's disease. Some medical conditions, like those that you see here, are actually treatable and in some cases totally reversible causes of cognitive changes. The most common of these is depression, which will frequently produce symptoms that look very similar to Alzheimer's disease or other forms of dementia, especially in older adults. Things like memory changes, difficulty with language, focus, and concentration. But there are several others, and included here are just a few of the most common. An illness, an infection, something like a urinary tract infection, or even a reaction to a medication, a new dosage of a medication, or an interaction with a different medication or supplement may cause symptoms that mimic Alzheimer's disease and other forms of dementia. Persons who are chronically dehydrated or who potentially have a vitamin deficiency may experience memory or cognitive changes. And certainly people who are struggling with sleep, who have unmanaged stress, they will frequently experience symptoms that look like dementia, especially in mid and later life. And very importantly, sensory loss, in particular hearing loss, will frequently produce symptoms that mimic a progressive condition like Alzheimer's disease. So here's a really important concept. Dementia is not one specific thing, right? So listed for you here are some of the most common non-Alzheimer's types of dementia. Lewy body dementia, vascular cognitive impairment, that's a category of different conditions, and frontotemporal disorders, FTD, also a category that includes several different types of dementia. Those are just a few, the most common of the non-Alzheimer's types of dementia. So each type of dementia is caused by a different pathology in the brain, and it produces its own unique set of symptoms. Mixed dementia is the term that we use when an individual is when a person has more than one kind of dementia at the same time. So common form of mixed dementia is Lewy body with vascular cognitive, Alzheimer's with Lewy body dementia, or Alzheimer's with vascular cognitive impairment. So the non-Alzheimer's dementias, and there are many others, by the way, there's dozens of non-Alzheimer's types of dementia, but they make up just about somewhere in the neighborhood of about 25% of all types of dementia. Between 60 and 80% of dementias are believed to be caused by Alzheimer's disease, that particular form of dementia. There's data out there that tells us more or less, but generally we kind of work with the estimate that it's about 75% or so of dementias in the United States are believed to be caused by Alzheimer's. So what exactly is it? Dr. Alois Alzheimer, who you see pictured here, first described the syndrome that would later come to bear his name. This patient, her name was Auguste Dieter, was admitted to a psychiatric hospital in Frankfurt where he was working as a pathologist at the turn of the 20th century. She was just 51 years old when she was brought to the hospital by her husband. Her symptoms included memory loss, disorientation, hallucinations, and radically changed behavior. She continued to deteriorate for several years, and upon her death, Dr. Alzheimer requested permission from her husband to conduct an autopsy. And within her brain tissue, Dr. Alzheimer found the presence of what we refer to today as the plaques and tangles that are currently considered to be characteristic of Alzheimer's disease. The plaques and tangles are made of two naturally occurring proteins called beta amyloid and tau. I hope you can see my cursor on my screen. Here I am pointing to what we would refer to as a beta amyloid plaque, which is in between the brain cells. And the tau tangles are actually inside of the brain cells, the neurofibrillary tangles. Today, we still don't understand what causes some brains to accumulate these proteins, and they do remain difficult to detect in living brain tissue. I'll be talking more about this when we get to the subject of diagnosis. So how is the brain affected? Here we see a graphic depiction of the damage that these plaques and tangles cause to the brain tissue. Again, Alzheimer's disease is neurodegenerative. It causes brain cells to die. This image that you see here is characteristic of Alzheimer's disease, that particular type of dementia, which is notable for the extensive damage that you'll see in the hippocampal region of the brain. And the hippocampus is involved in the creation and storage of short-term memory. So that is why we see that particular symptom so early and so prominent in most people with the Alzheimer's type of dementia. Every type of dementia has a different cause and affects different regions of the brain. The specific type of protein that is accumulating, where in the brain it's accumulating, which of these lobes is being affected, and how extensive the damage is will determine what symptoms the person experiences and how severe they will be. There are so many factors that influence the course of this disease: a person's age, their overall health. It can be very difficult to predict exactly what symptoms, what changes, and what progression any individual person will experience. So before I move on, and we're going to get into the symptoms of dementia first, I have been receiving a couple of questions. I've just been answering them as I've been going along, but if anybody's got any questions related to Alzheimer's disease, the disease itself, or any of those related dementias, go ahead and submit those now. Otherwise, I will keep us moving. Okay, Well, just again, just feel free to submit those questions as we go. I am keeping an eye on it, and I'll try to answer them as we go. Let's talk about the common symptoms of Alzheimer's disease and other forms of dementia. Everyone will experience some changes in their memory and their thinking as they age. And it's really important that we know the difference between what we call normal age-related changes and something that may be cause for concern. So keep in mind that the symptoms of dementia represent a marked change from baseline, what was normal for that individual person. And the symptoms are significant enough. They're not just sort of minor annoyances. They're significant enough that they interfere with daily activities. The symptoms of dementia, we lump them into 4 primary domains, and I'll talk about those next. Memory, thinking, physical changes, and behavior. So let's start with memory. Memory, as I mentioned when I was showing you that visual of the brain, short-term memory in particular is one of the prominent symptoms of the Alzheimer's type of dementia, but most other types of dementia as well. It's a pretty common symptom across various types of dementia. Memory will change for us as we age. It is normal for us to experience more difficulty with remembering names, finding words. We definitely lose things more often. These are, again, sort of minor daily annoyances that pile up on us, and we feel them as we age, but they don't necessarily represent something that we should worry about. When should we worry about it? Some examples related to memory symptoms related to dementia, getting lost in a familiar place, right? Generally not having good wayfinding ability throughout your life, this is nothing to worry about. But if you are having difficulty navigating your way around your own familiar neighborhood, this would not be a normal age-related change. As I mentioned before, it is common and normal to misplace things more often, our glasses, our phone, our keys, right? We're having difficulty paying attention and focusing. That type of memory change is not something to worry about. It's when you're actually forgetting the function of an object. Holding your keys, for example, and not recognizing that this is the object you need to insert into the lock to get the door open. And so hopefully you see the difference there. Normal thinking related changes as we age. Also, sort of a category to be expected. It is harder for us to learn new things. We are slower at learning and at solving problems. Anybody that has tried to learn a new language or pick up a new musical instrument in middle or late life knows this. We absolutely can do it, but it takes us longer when we have an older brain than when we were younger. And certainly it's very common for us to struggle with attention and concentration. We just simply aren't as good at multitasking as we get older. These are normal age-related changes in how we think and nothing for us to necessarily worry about. Some examples of things we might want to worry about or bring to our doctor's attention. When we're experiencing new difficulties with language, not just forgetting a word, but actually losing parts of your vocabulary, having a hard time processing what other people are saying or what you are reading, difficulty with writing or working with numbers. And I want to just a quick caveat on difficulty with writing and with all of these symptoms, really. We're talking about changes that are not explained by other conditions. So for example, a person may be struggling with handwriting, but it could be because they have vision changes, or it could be because they have arthritis. So we're talking about new difficulties that are not explained by other physical conditions. It's also not a normal age-related change to experience changes in the way you sort of use your common sense, your judgment, the way you use insight or apply reason to solving a problem. So here again, I want to point out we're talking about changes from what's normal, from what's baseline for that individual person. So if a person, sort of made bad decisions and didn't think things through well throughout their life, that's not necessarily something for us to worry about. It's when it represents a real change from how that person used to function. Maybe somebody that was always a plotter, a very methodical, slow thinker and problem solver who suddenly becomes very impulsive, for example. There are physical symptoms of dementia as well. Some physical changes are normal and to be expected as we age. Changes to our vision, hearing loss is very common in older adults, and other sensory loss. So a dulling, if you will, of a sense of smell or taste, for example. It is normal for us to experience reduced muscular strength and reduced flexibility as we age. Not to say that there aren't things we can do to mitigate these things, just to say they are normal and to be expected. But there are some physical symptoms of dementia we should be aware of. In particular, changes to the visual spatial field are very common in many different forms of dementia, wherein an individual's field of peripheral vision will become much narrower. This can happen even very early on in the very early stages of dementia. So changes to that visual spatial field, which will frequently then cause difficulty with balance and coordination because individuals struggle to be able to interpret contrast or the change of surface level on the ground, for example, when they're walking. So changes to that visual spatial field and other sensory processing problems can happen as well. So as I said, it is normal to experience changes to your hearing, to become hard of hearing as we age. But what will happen in persons who are living with the early stages of dementia is not just difficulty hearing something, it's difficulty interpreting what that is. Right? So being able to hear, for example, a siren. If you're driving a car and you hear a siren, there's a lot that your brain has to do to help you come up with the proper response, to help you to understand what you're hearing, what it means, right? That's an emergency vehicle and I should pull over into a safe place over to my right as soon as I can, and where it's coming from, right? What direction? Is it ahead of me, behind me? Is it around the corner? So we see difficulty with that type of sensory processing, not just in vision and hearing, but also with smell, with tactile sensation, being able to tell, for example, that it's very warm outside and I need to dress in a lighter type of clothing, for example. Behavior changes are important to talk about because changes to our behavior are not a normal part of aging, unlike these other domains that we've been talking about. So when we see changes to a person's behavior or we experience them in ourselves, it doesn't necessarily mean that these are the symptoms of dementia, but it does mean that something is going on. Right? It could be a mood disorder, it could be stress, it could be a medical condition, it could just be a period of intense grief, for example. But behavior changes do signal that something is going on with a person's brain. So mood and personality changes, just very important to recognize they're not a normal part of aging. When we see people beginning to withdraw socially from people or activities that they formerly really enjoyed, we should be aware of this and not sort of chalk it up to normal old age. It isn't. We'll see people struggling with the initiation of new tasks, sort of like a symptom similar to depression, just having a hard time getting started. Do you feel like going for a walk? No, right? Just always saying no, not wanting to get things started. Overall, we're talking about just an overall change in the person's demeanor, changes in the way they normally do things, just changes in the way they typically live their lives. I'm going to talk next about risk factors, screening, and diagnosis, and then we'll pause for some questions. Talk a little bit about the impact of Alzheimer's disease. Currently, there are well over 5.5 million Americans who are living with Alzheimer's disease. And dementia currently affects 1 out of 9 people over the age of 65 in the United States. The risk of developing Alzheimer's and other forms of dementia does significantly increase with age. Here in our county, in San Diego County, we have nearly 84,000 people who are living with a diagnosis. It is the 6th leading cause of death in the United States. It is the 3rd leading cause of death here in San Diego County in people who are over age 65. That is simply a matter of age being the primary risk factor. We have an older demographic than many other parts of the country. It probably goes without saying, but it's still important to say it. Alzheimer's and other forms of dementia take a significant emotional, physical, and financial toll on the individuals living with the diagnosis, the friends and family and care partners that support them, on our healthcare system, certainly, and just on society overall. Currently, there is no cure, there is no effective form of treatment for the disease, and there is no known means of prevention for Alzheimer's and other forms of progressive dementia. So who's at risk for developing Alzheimer's disease? Basically, all of us. Age is the primary risk factor. As I mentioned, 1 in 9 people over age 65 is living with Alzheimer's or another form of dementia. By the time you're age 85, that risk has gone up to about 1 in 3, about 40%. So age is the primary risk factor for most of these diseases. Being female is a significant risk factor for the Alzheimer's type of dementia in particular. Other health factors, hypertension, heart disease, diabetes, and hearing loss. These health factors are not causal, but they are associated with higher rates of developing Alzheimer's disease and other forms of dementia. The genetics of Alzheimer's disease and other forms of dementia are tricky. Family history is a risk factor. If you have a first-degree relative who has Alzheimer's or a related dementia, first-degree relative being a parent, sibling, or child, then you are considered higher risk. But in most cases, in the vast majority of cases, Alzheimer's disease and other forms of dementia are not inherited in that strictest sense. Certainly, we have identified a couple of particular genetic mutations that reside, genetic markers that reside on the 21st chromosome, and individuals who carry a particular combination of these genes are either considered to have slightly higher risk or slightly lower risk, depending upon that particular combination. But in most cases, again, the vast majority, it's a very small percentage of cases that are actually caused by a genetic mutation. These are typically only risk genes, and people that have the protective particular genetic combination can certainly still develop Alzheimer's disease. Individuals who do have the higher risk combination can certainly not get Alzheimer's disease. So your DNA, your genetics are a small part of the picture, but certainly family history does play a role. Individuals who have lower levels of formal education are believed to be at higher risk of developing Alzheimer's disease and related dementia. Persons who have sustained head trauma, in particular, a head trauma that causes a concussion, a loss of consciousness and a concussion. There is a known causal relationship between head trauma and one particular form of dementia, chronic traumatic encephalopathy, CTE. But head trauma does actually increase the risk of several different types of dementia. And the last of the known risk factors for Alzheimer's disease in particular is Down syndrome. So individuals with Down syndrome have 3 copies of the 21st chromosome, and on the 21st chromosome resides one of those genetic markers that causes the brain to overproduce one of the proteins associated with Alzheimer's disease. So individuals with Down syndrome, this is one of those exceptions that I was referring to before. Individuals with Down syndrome do have a very high risk of developing Alzheimer's disease, and that is strictly due to genetics. So those are the known risk factors for Alzheimer's disease. Just a couple of things I want to say about that. First, there is significant ethnic disparity in the United States today. Alzheimer's disease is more prevalent among African Americans and in the Latinx population than among whites in the United States today. These disparities are believed to be related to those other health factors that I mentioned before. There are significant health disparities, including higher rates of heart disease and diabetes in particular in these populations. And then finally, in sort of looking through that list of risk factors, I just want to point out, you don't see any environmental causes. There are no known environmental risk factors or causes of Alzheimer's disease or other forms of dementia. So nothing in the food supply, nothing in the air or the water, no particular chemical exposure, for example, that is known to cause Alzheimer's disease. So what can we do to lower our risk? The bottom line is take good care of your heart. What's good for your heart is good for your brain. But there is some good, large-scale, validated, longitudinal data out there that shows us that doing these things that you see listed here can help lower your risk. I'm careful not to use the word prevention here. We don't have a known way to prevent Alzheimer's disease and other forms of dementia, and certainly you can do all the right things and still get Alzheimer's disease or another form of dementia. But by eating a healthy diet, and in particular, it's the Mediterranean diet that has been studied pretty extensively and shown to lower risk. That's a diet that is rich in vegetables and fruit and whole grains, and notably, it is not a low-fat diet. A brain-healthy diet does have plenty of fat, but those fats come from plants and they come from cold water fatty fish. So olive oils, nuts, seeds, that type of thing. Eating a healthy diet, getting plenty of exercise and physical activity. Obviously, it's good for your heart and it keeps blood flowing through your brain. Your brain is the biggest user of the blood supply in your body. So getting plenty of exercise is essential to overall health and certainly to your brain health. And there is some evidence that people that engage in endurance activity, sustained aerobic activity, do actually have higher levels of nerve growth factor in their brain and a larger hippocampus. So interesting research on that note. Staying intellectually active, staying cognitively engaged, doing puzzles. People ask me all the time, should I do crossword puzzles? Should I do Sudoku? And the answer is yes, if you like doing those things. Engage in activities that challenge you, that make you solve problems, that keep you curious and keep you, above all else, experiencing new things. That's really the key to intellectually stimulating activity. Meet new people, go to new places, and solve new problems in new ways. Maintaining a healthy network of social connections. We are primates that are wired for connectivity, and as we're all currently experiencing right now, when we don't get to be as socially connected as we're used to, it can really be a challenge. Staying socially connected is deeply important to our overall health and certainly to our brain health. keeping track of your emotional health, recognizing the signs of anxiety, depression, unmanaged stress, for example, getting those things in check because they certainly have an impact on your overall health, but they also appear to have an effect on your brain health. And quality sleep. There's a growing body of research out there that tells us about the connection between a person, the quantity, and importantly, the quality of sleep that people get and their risk of developing Alzheimer's disease. I like to talk about sleep as one of the most important of these factors in lowering your risk, simply because it's just so difficult to do any of the rest of it. If you're tired, if you're not well rested, it's very difficult to do the shopping and meal preparation and get out the door for that physical activity that you need to do. So all of these things will lower your risk of developing dementia in the first place, but it's also really important to know that I would like to mention that if you're already living with Alzheimer's disease or another form of dementia, you've still got billions of perfectly healthy brain cells. So we want to encourage people to do everything they can through all of these types of activities to keep their brain as healthy as possible throughout the disease process. There is not currently evidence that eating a healthy diet, exercising regularly, remaining cognitively stimulated, for example, or socially connected, that these things will actually halt or reverse the progression of Alzheimer's disease or other forms of dementia. But what they do is that they keep the rest of the brain tissue healthy and functioning at its highest level. So regular screening is really important for a variety of reasons. It's generally recommended that everyone age 65 and older have a memory screening on an annual basis, or to start at a younger age if you have significant risk factors. But really, it's never too early to start with doing memory screening. Memory screening is typically done through one's primary care provider, but it's also available through a variety of different community-based organizations, including us at Alzheimer's San Diego. They're usually very brief and simple tests, paper and pencil and verbal testing. They take just a few minutes. They can be done, again, in the primary care office, or they can be done in a community setting. And they are used not for diagnosing, simply to detect changes in a person's memory or their cognitive processes that appear to be more significant, more severe than normal age-related changes. Really important to engage in regular screening for a variety of reasons. First of all, when I was talking about the symptoms of dementia, I was referring to the difference between normal and not normal for you as an individual person. That's your baseline. So without regular screening, it can be difficult to know what is normal, what is baseline for this individual person. You're having screening on a regular basis, then the provider who's doing that screening is more likely to be able to detect changes in your memory and your thinking early. One of the great dilemmas of Alzheimer's and other forms of dementia is that if I am the person living with the symptoms, I may be the last person to recognize that. Many people with dementia are not able to recognize when they're beginning to struggle and when they're starting to have problems with their memory. So if I've been getting memory screening done on an annual basis, then it may be my doctor who is able to detect those changes earlier than I am. It's also really important, remember when I was describing those treatable and reversible causes of memory changes, this is one of the most important reasons to get screened on a regular basis. If it's depression, if it's an infection, if it's a thyroid problem, for example, or a nutritional deficiency, we can rule out those reversible causes. We can catch them early and generally reverse those cognitive changes. So I am asked all the time, Well, if there's no cure, if there's no treatment for this disease, then why would I want to get a diagnosis? Why do I need to get a diagnosis? It's important to remember there are treatments for the management of symptoms, and I'll talk about some of those here in a moment. Without knowing what type of dementia you have, what region of the brain is affected, it's very difficult to know what kind of medication, what kind of treatment to try, what type of symptoms can we expect, what do we need to do, what do we need to be thinking about in terms of care planning. As I'll be talking about, there are a few FDA-approved medications to address some of the symptoms of Alzheimer's and other forms of dementia, but they really are only effective if they are started early, while the chemical changes in the brain are still fairly mild. Early detection and an accurate diagnosis gives individuals and families opportunity, they have the time and the opportunity to have those important conversations about the disease, about the future, to talk about who you want to be your decision maker down the road, should you lose the capacity to make or communicate your own decisions. And then if you're interested in participating in research, you have a much greater opportunity to do so if we catch these diseases early, while the person is still in the early stages of the disease. They have more capacity to give that informed consent that is required in order to participate in research. Getting a diagnosis is not a simple matter. There are no standard protocols for how we do this at the moment. We're working on it, but at the moment, it is typically a pretty challenging process for a lot of people. We do recommend starting with your primary care provider because they know you best. If they have had training, certainly a primary care provider can diagnose Alzheimer's disease or other forms of dementia, but they may wish to refer you on to a specialist. Or you might just wish to see a specialist yourself. So some of the types of specialists that you might see are listed for you here. A neurologist, a geriatric psychiatrist. Psychiatry is often involved in the diagnostic process because there's so much overlap between dementia and depression in particular. A neuropsychiatrist or a neuropsychologist, these are specialists who work with diseases of the brain, so psychiatric issues or psychological issues related to neurological conditions. So neuropsychiatrists and neuropsychologists are typically involved in the diagnostic process. They do the testing, but not necessarily the ongoing treatment of a person who's living with dementia. And a geriatrician is an internal or primary care medicine provider who specializes in working with older adults. Their specialty is not necessarily dementia, but because they work specifically with older adults, they tend to have a lot of experience and a lot of training in this area. So what would happen when you're seeking a diagnosis? Again, there is no standard protocol, but some things that you might expect from the process. Certainly, they're always going to start with a comprehensive medical history, doing a physical, and taking a lot of lab work. So what they're looking for there are those treatable and reversible conditions that I was describing before. Alzheimer's disease and most forms of dementia are often referred to as diagnoses of exclusion, meaning we just rule everything else out first because Alzheimer's can be so difficult to detect in the brain tissue of living people. We rule everything else out first, and then we start with doing neurological exams, doing neuropsychological testing. So this is the kind of testing. It's pretty intense. It's more detailed than a simple memory screen. It evaluates a person's function in various cognitive domains, not just memory and language. brain imaging is not always, but frequently ordered to allow a specialist to have a look at the shape or the volume of the brain to detect evidence of damage. There might be evidence of a vascular condition, for example, a history of stroke or a series of small strokes. Typically, it's CT scans or MRIs that are used. An MRI is typically is the most common type of brain imaging that is ordered for in the diagnostic process. PET scans are sometimes used. These will help a doctor or radiologist analyze the amount of activity that is happening or not happening in different regions of the brain. So what they're looking at in brain imaging, remember when I was showing you those plaques and tangles that Dr. Alzheimer found in his patient, we don't currently have readily available technology that allows doctors to look inside of brain tissue to confirm the presence of those plaques and tangles that I was referring to earlier. So typically what they're looking for in a CT scan is evidence of stroke, for example. With an MRI, they might be looking for a loss of volume that might tell you this is characteristic of a frontotemporal type of dementia, for example. Or no, we see a lot of atrophy in the hippocampal region, so this looks like Alzheimer's disease, for example. So they're not doing that brain imaging, at least not yet, with the goal of detecting those plaques and tangles, but instead they're taking a look at the overall picture of the brain and seeing how it looks, how it functions differently from a normal brain. But new advances are on the horizon in that regard, and we hope very much to soon have access to better diagnostic tools, such as PET scans that can detect the presence of beta amyloid or tau, retinal scans, spinal tap, being able to see the presence of these proteins in the cerebrospinal fluid, and ideally, we'd have a simple blood test that would be able to confirm the presence of Alzheimer's disease. So these are not yet widely available, but they are definitely on the horizon. Finally, a good workup will always include conversations with other people, a knowledgeable informant, as medical providers will say, because as I mentioned, it is often the case that the person with dementia has limited insight into the changes that they're experiencing, and it can be very helpful for the doctor to be able to talk with someone else about how is this person's function different today than it was a year ago, 2 years ago, for example. So I'm going to pause here. I do have a couple of questions that have come in through the chat. I have a question here. Is it common that even if a person with dementia forgets someone explicitly after meeting them, they may remember them implicitly, such as acting a certain way toward the person based on how the person makes them feel? Absolutely, this is a really interesting question. When I was going through the different symptoms of dementia, I mentioned that it can be difficult to remember names or some of the sort of semantic facts about a person or a place. But certainly it's absolutely possible, and in fact very likely, that a person with dementia retains what we would call kind of an emotional memory, that, you know, I may be looking at you and I may be able to tell that I know you and that I like you. I might even know you're one of my children and that I really love you, but gosh, I really just can't remember your name right now. So absolutely, that is possible, and in fact, it is quite common that we see that, the retention of an emotional memory. I had a question about the lifestyle factors that I was talking about: diet, exercise, cognitive stimulation. Will those lifestyle factors help retard the progress of the disease? And unfortunately, no, they are. I should be clearer. There isn't any evidence yet that any of those things actually reverse or halt the progression of the disease, meaning the spread of the plaques and tangles, for example, throughout the brain tissue. But in terms of slowing down the functional losses, absolutely. And in particular, exercise, there's a fair amount of evidence that exercise really is probably more effective than any other intervention we have in terms of helping keep a person as healthy and as functional as possible. And then I have a question here. I've heard of some scanning, CT or otherwise, to see how progressed the dementia is. Is that recommended or not worth putting the person with dementia through? A really good question, and actually a question that I just asked of a doctor recently, because it's really important and something a lot of people struggle with, but unfortunately there isn't sort of a universal across the board answer to that. For most people, once you've received a diagnosis, once the imaging has been done and a person has received a definitive diagnosis, then additional scanning is not typically recommended. There's generally not a lot to be gained from that. But certainly there could be instances wherein a doctor would want to monitor vascular damage, for example, or the progression of atrophy, the loss of tissue in the brain. So I can't say definitively yes or no. Is it worth putting the person with dementia through CT scanning, MRI scanning? It can, in fact, be very stressful and very difficult, but that's a very individual decision for you and the doctor to make. Okay, I'm going to keep us going here. And we will talk next about what to expect as this disease progresses. If you or someone that you know receive a diagnosis, let's talk a little bit about the progression of Alzheimer's disease and other types of dementia, what we might see. So typically, we're going to see a very long, slow, and steady decline in function over time. Something I want you to notice about this graph that I've put up on the screen here is that there aren't any numbers on it, right? How long will this disease last? How long will the early, the middle, the late stage be? How severe will the symptoms be? None of these things are easy for us to predict. No two people experience any one particular type of dementia exactly the same way. So we typically say it's, can be anywhere from 2 to 20 years. It's a highly variable disease that, as I mentioned before, is heavily impacted by the person's overall health. So, but there are some general patterns that we can plan for and that we can talk about. Before I do that, I just want to say this is a really important message. Getting a diagnosis of Alzheimer's disease or Lewy body dementia or vascular cognitive impairment, this does not mean immediate incapacity, right? A person's ability to make decisions for themselves, to have legal and decisional capacity is not based on whether or not they have a diagnosis. It's based on their level of function. And most people are going they're going to spend a lot of time in the early stages of the disease. So in the earliest stages of the disease, we see usually memory loss, and usually it's short-term memory loss. We see moments of confusion and disorientation. We see difficulty with the instrumental activities of daily living. That's insurance terminology for things like driving, paying the bills, being able to do your shopping and prepare your meals, for example. But individuals in the early stages of the disease do not require assistance with the basic tasks of daily living, bathing, grooming, getting dressed, those types of things. In the middle stages of the disease, we'll see more memory loss, longer periods of confusion, more frequent disorientation. Many people's communication will change significantly in the middle stages, more difficulty with language. Some people will become more quiet. They simply communicate verbally less. The middle stage of the disease is really defined by beginning to struggle with and needing some assistance with the basic activities of daily living. So that's the bathing, the grooming, getting dressed, walking, transferring, those types of things. When a person requires some assistance with those types of personal care, that's typically what we refer to as the middle stage of the disease. It could just be that the person needs reminders. It may not be that they need physical assistance with those things, but they need some kind of prompting, either verbal or physical assistance with that. The middle stage of the disease is where we really need to be attuned to some of these safety concerns that I'm going to be talking about here in a little bit. Individuals in the mid stage of the disease are at exceptionally high risk of wandering, getting lost, because typically they are physically as well as robust as ever, as they were before, but they've lost some judgment, they've lost some insight. They have that more significant memory loss and confusion that puts them at a higher risk of injury or getting lost, for example. And the late stage of the disease is in most cases, the shortest stage of the disease. We can't really give estimates for, how long, how many years does a person typically live in these various stages of the disease. It's very gray, it's very varied from person to person, but for most people, the late stage will be the shortest of these stages. We typically see very limited verbal communication, little to no verbal communication. It's inevitable that a person in the late stages of the disease will require 24-hour supervision and help with their activities of daily living. Not uncommon at all for persons in the late stage of the disease to have difficulty with chewing and swallowing, and very limited physical activity and independent mobility. It's difficult but important to understand that Alzheimer's disease and other progressive forms of dementia, these are fatal illnesses. I mentioned before that Alzheimer's is the third leading cause of death in people over age 65 in San Diego County, and that can be sort of a confusing concept. How exactly do you die from a memory problem? Well, very important to recognize the memory problem is the symptom of the fatal disease, right? The brain is really the control center of everything in the body. And so as the disease spreads into different regions of the brain, in the late stage, it will reach the parts of the brain in the cerebellum and the brainstem that control a lot of the involuntary functions. So we will see people can die with dementia, but from something else that happens, or people can actually die from dementia due to what is essentially brain failure, right? When messages are not being sent to the vital organs to keep the heart beating, to keep the lungs functioning, right? Then that will essentially sort of slowly shut down the bodily functions. But it's really important that we not just think about Alzheimer's disease and other types of dementia as just this series of physical changes and losses. Throughout the disease, people living with dementia can absolutely be a part of their own care planning process, make and communicate their decisions. They can let people know when they like what's happening and they don't like what's happening. They can express feelings. They can respond to emotional connection. People are able to continue to engage in the activities they've always loved. Work and recreational activities will certainly, as the disease progresses, have to be changed and modified. But with good, creative, thoughtful planning, we can keep people with dementia fully engaged with the people and the activities that they've always enjoyed. And very importantly, we talk about this in a lot of our education programs. People with dementia can connect to us through various sensory and nonverbal forms of communication. So just encourage you to keep in mind that every stage, early, middle, and the very late stages of the disease, every person with dementia is able to love and to know when they are loved. So now let's talk a little bit about how to live as well as possible throughout the progression of this disease. There are 5 FDA-approved medications for the memory and cognitive symptoms of Alzheimer's disease. Now, you heard me say before that there is no cure, there is no treatment. So what's the difference here? These medications work on the symptoms themselves. They don't actually have any impact on the pathology. So in Alzheimer's disease, for example, these medications don't stop those plaques and tangles from accumulating or from spreading into different regions of the brain. But for many people, they will delay the progression of those memory and cognitive symptoms. So they fall into 2 classes of drugs, the cholinesterase inhibitors and the glutamate regulator. So Aricept is the most common of those cholinesterase inhibitors. That is typically it's prescribed most often. That's typically where doctors start. And if it's not well tolerated, they might try one of the other 2, Exelon or Razidine. So the cholinesterase inhibitors, and then there's Namenda. That's the brand name of memantine, a glutamate regulator. So these are 2 different categories of drug, meaning that they can be taken at the same time. They're safe to be taken together. Aricept and Namenda is a very common combination. Those 2 drugs are frequently prescribed together. So Namzaric is a newly available drug, which is really just a combination of extended release memantine or Namenda and donepezil or Aricept. It's a combination of those 2 very commonly prescribed drugs. These medications don't work for everyone. They're not prescribed for every type of dementia. They're FDA approved for Alzheimer's and used in some other forms of dementia as well. They typically have a window of effectiveness that lasts somewhere in the neighborhood of 2 to 3 years. And they do frequently cause side effects. Nausea and diarrhea are very common side effects with these drugs. So they're not ideal, but they are what we currently have. We're very hopeful we'll have new drugs in the near future. But keep in mind that other medications besides these can and are often prescribed to address other symptoms of the diseases, such as anxiety, depression, agitation, sleep disturbance, for example. So these are not the only medications that can be prescribed to people with dementia. These are just what we sometimes refer to as the cognitive drugs or the memory drugs. The medications are only a piece of the disease management puzzle, if you will. There's lots of changes we can make that will help to address some of the cognitive, physical, and behavioral symptoms that a person with dementia may be experiencing throughout the progression of the disease. So it's really important that we learn new types of communication when it comes to living with dementia and caring for somebody who's living with dementia. We really have to learn to stop kind of arguing, correcting, confronting people with dementia when the symptoms of their disease are causing them to remember things incorrectly, when they have a different perception of reality than we do. So these they're difficult, but they absolutely can be learned. And we have a lot of support available at Alzheimer's San Diego to support people in learning these new communication techniques. But generally speaking, we're talking about just kind of paring things down, simplifying the environment as well as the way that we communicate. Giving the person fewer distractions, adjusting our expectations of ourselves and of them, and of course, attending to the needs of the care partner is a really important part of this adapting to the new normal of living with dementia. We really can't properly care for a person who's living with dementia if we aren't also addressing the needs of the people who support them day in and day out. So we do this by addressing the physical and emotional needs, again, both of the person with dementia as well as their care partner. We can make adaptations in the person's environment, changing things about the way that a home is laid out, the setup in the bathroom, for example, making sure that stairs are properly lit and that there's handrails. Simple environmental modifications can make a huge difference. We might also consider adapting the environment on a larger scale, making decisions about leaving the home and moving into a supported living environment, for example. And then we have what we call the behavioral interventions, learning how to redirect someone's attention to something that is more soothing, that is more calming when they're becoming agitated, for example. Learning those communication techniques of just validating that person's experience, right? If they're feeling fearful, if they're feeling anxious, to not dismiss that, but to let the person feel heard and understood makes a huge difference in terms of the day-to-day quality of life, both for the person with dementia and for their care partner. So I can pause here to answer any questions that you might have about those 3 stages of the disease or any of those symptom management techniques that I was talking about before. I'm looking through the chat, and I did address a couple of questions that were coming in as we were going along, and I don't see any new ones coming in. So I'll go ahead and keep us moving. We'll talk now about planning ahead, thinking ahead about safety and well-being and support, both for the person with dementia and the care partner throughout the duration of this disease. So briefly, these are all very big, very complicated, and very important topics. But I just want you to be aware of some of the key safety considerations that really need to be thought about, talked about, and planned ahead for when a person receives a diagnosis of dementia. I talked about those visual spatial changes and the ways that they can change a person's balance and coordination. So thinking ahead about changes we can make in the person's environment or in their activities to prevent falls. This could also mean checking their medications to see if any of their medications increase their fall risk. And keeping people sort of as strong and balanced as we can with plenty of exercise, for example. There's lots we can do around the house to avoid injuries, setting accidental fires by leaving the stove on, for example. Making mistakes with medication can certainly have some pretty significant consequences. And managing medications is difficult for people who have no memory problems. Keeping them all straight, knowing what they're all for, knowing how you're supposed to be taking them. These are significant challenges, especially for a person who's living with memory and cognitive changes. Preventing abuse, a really important consideration, especially for persons with dementia in that middle stage that I was talking about before, where they may present socially and conversationally very normally, but have a lot of difficulty with judgment. So individuals with dementia are known to be about 3 times, have about 3 times the risk of being victims of elder and dependent adult abuse than the general population. So doing things like getting mail directed somewhere else, sort of making decisions about who comes and goes around the house, these things can go a long way in terms of preventing abuse. Issues of driving and firearm safety. These are very important public health issues when it comes to persons who are living with dementia. They are among the hardest to talk about. Taking away the car keys, taking away a person's access to their firearms. These are very tricky subjects, but they're very important to talk about sooner rather than later. We have complicated rules around these things, the DMV reporting laws here in California, as well as transfer of firearm ownership. These are complicated laws, but we can we can support families in having these conversations and making these decisions safely and making them sooner rather than later. Identifying caregivers who are in need of support is a really important aspect of taking care of a person who's living with dementia, right? Recognizing that this is definitely a 24/7 condition for everyone, for the person who's living with the symptoms and for everyone who cares about them. So meeting the needs of those caregivers, getting them breaks, getting them connected to education, to support, or just a good old-fashioned respite when they need it is really important. And then I mentioned the behavior of wandering. Wandering can happen absolutely at any stage of the disease, not just in that middle stage. We have data that tells us about 60% of people with dementia wander at some point during the course of the disease. And I would actually venture to say that it's probably higher. I think 60% is what gets reported. But wandering is a very high-risk behavior. It's the term that we use simply for getting lost, right? When a person with dementia leaves in search of someone or something or someplace in a moment of confusion and disorientation, it's a really high-risk behavior. But we do have some terrific local safety resources here in San Diego County to address this. So at Alzheimer's San Diego, we have classes, we have tip sheets. Our social workers can help families in terms of thinking about ways you can modify the home, change the patterns of the person's activity to prevent the likelihood of wandering in the first place. But if wandering does still happen, and it frequently will, we really just have to be focused on getting that person back home as quickly as possible. So we have two resources in particular. One is the San Diego Sheriff's Department's Take Me Home program, available on this at this website that you see here, sdsheriff.net. Take Me Home is a free online database operated by the Sheriff's Department, wherein information about persons who are likely to get lost is kept in a safe and secure environment, a good close-up photograph of their face and some key information about that person, so that in the event that the person is lost, their care partner can just call 911 and say, my loved one is in the Take Me Home registry. That information goes out to the local law enforcement jurisdiction immediately so they can begin a search. And they've got some information to work with, right? They know what the person looks like. They know some key things about them and where to begin that search. Medic Alert, these are the bracelets or the pendants that you're probably familiar with. They're frequently used in other types of medical conditions. And memory loss, Alzheimer's disease, and other types of dementia, these are medical conditions as well. So we really encourage families not only to sign up in the Take Me Home database, but to obtain a Medic Alert bracelet or pendant or wallet cards, whatever works best for you, so that in the event that a person with dementia is found by a first responder or a Good Samaritan, they can be identified as having memory loss. This connects, there's a phone number to call, connects to a nationwide database, and we can get that person back home as quickly as possible. And I just want to say a quick note on the Medic Alert, that we really encourage primary caregivers to have a Medic Alert identification as well. If you're the primary support to somebody who's living with memory loss, someone who relies on you, it would be really important that a first responder know that about you in the event that something happened to you, that they can go check on that person and make sure that they're okay. So these are just two of many, just an array of safety resources that you can find on the safety page of the Alzheimer's San Diego website. We can connect people to tools for GPS to help with wandering response, other type home safety checklists, other types of safety resources. We also we maintain a gun lock program. We can give any number of cable-style gun locks to anyone who needs them to secure a firearm so that it cannot be discharged. This is a wonderful low-tech, zero-cost solution when firearms cannot be removed from the household. So really important to just kind of a reality check that living with dementia, this is a physically, emotionally, and financially demanding journey, and it is important to prepare well for it. It can be a really good one, but it does take some thought and it does take some planning. So just a couple of things to keep in mind: educating yourself and developing your skills, those communication techniques, those modifications that you can make around the house if you're a primary caregiver to somebody who's living with dementia. It's not sort of common sense how to help someone with dementia get dressed, for example. We do have to learn these things, and there are resources out there for learning how to do them. Build a strong support network. If you're a person who's living with memory loss or cognitive changes, it's critically important that you start now. Talk to people about what's going on. Ask for their help. Let them know you're still you, and you want to be a part of their support network, and you want them to be a part of yours as well. Have opportunities in your life for regular breaks. That's what that word respite means. It's just rest, getting a break, whether that means a week-long vacation or just a couple of hours a day or just 5 minutes that you can sort of step away, get a break from each other, clear your head, and get ready for the next leg of the journey. Respite is critically important. Do not let this disease take over everything, such that you're not attending to your overall physical or mental health care needs. There's still a lot of life to be lived, and I think more than anything, it can be very hard to see this at the beginning of the journey for a lot of folks, but being able to smile and laugh and maintain a sense of humor about all of this. All the families I've worked with over the years, they will all tell you that being able to just enjoy the silly moments, the moments of absurdity that inevitably come during the journey with dementia, that's really what's kind of kept them healthy, kept them going. So it's really never too early to start these conversations. And again, we have a lot of resources for this at Alzheimer's San Diego. Start talking about the advanced healthcare directives. Have you established a durable power of attorney for healthcare, for finances, for example? If you created those documents many years ago, now is a great time to revisit them. Having those conversations about staying home and how to do that safely and how to do that well. Having those tough conversations about driving. Most of us, with or without dementia, will need to plan ahead for a time that we're not driving. Start having that conversation now. Start looking at the costs of long-term care, hiring in-home care, going to an adult day program, moving into some type of a residential care setting, assisted living or memory care. The costs can be fairly shocking if you aren't prepared for them. So start thinking about those alternatives and those options, and thinking about what your financial resources are for those, exploring what benefits might be available to you. Again, engaging that support system, getting the people around you up to speed on what's going on with you and what kind of help you need now and what kind of help you might need down the road. And above all else, focusing on keeping your physical and mental health as strong as possible. So this is a really nice visual look at who we are at Alzheimer's San Diego. Unfortunately, at the moment, given the current public health crisis we find ourselves in, many of our resources and programs, because they are provided on a personal, in-person, kind of a high-touch kind of a organization that we are, many of these services are not available, or they're just modified in some way. But do know that we are here for you. We have a robust education program. We have support groups that meet all over San Diego County, and we are currently in the process of launching several online support groups for the time being. Take Charge is an education program for people with a new diagnosis and care partners to go through together. We have in-office and community-based social activities and outings to keep people with dementia active and engaged, to keep their care partners interacting with other people. Social isolation is your enemy here when it comes to living with dementia. We want to keep you active and socially connected. Our team of dementia experts are as available as ever. While we can't currently offer in-home family consultations the way that we normally do, they remain available by phone, by email, by live chat, to answer questions, to connect you to resources, to help you do some practical problem solving, or just kind of talk you through a difficult moment, through a difficult day. That's what we're here for. We can connect you to a variety of different types of respite, meaning that those services that will give you a little bit of a break through our volunteer companion respite program, as well as in-home and residential respite care services that are available elsewhere in the community. If you're interested in learning about research opportunities, we maintain current lists of all of the organizations that are conducting clinical trials related to Alzheimer's and other forms of dementia. And we have an annual large, really exciting research event currently scheduled for June called Date with a Cure, where we bring in local researchers to talk about what's going on in the world of Alzheimer's disease research and let you ask questions and hear directly from them. And then finally, Coping with Caregiving is an education and support program specific to care partners for people who are living with dementia. So as I mentioned, many of those programs, because we aren't able to offer face-to-face in-person programming at the moment, they are on hiatus, but we have an amazing array of information and resources available through our website. We've got tip sheets, we have a video library, and we're building our online educational library all the time. And then our social workers, again, remain available to help connect you to resources, to provide emotional support. They are available by phone, by email, and again, by live chat right through our website. Monday through Friday, 8:30 to 5, our dementia care consultants are available if you need anything. So here are some sources. We really encourage you to get Alzheimer's disease and brain health information from credible, reliable, authoritative sources. There's a lot of people out there that are selling you stuff. But fortunately, there are a lot of good sources for information as well. So I've listed several of the most credible sources for dementia and brain health information for you here. So in summary, I haven't seen any other questions come in that I haven't answered as we've been going along. But if you've got any more, we have another couple minutes. Feel free, send me a chat and I will address that. But here is what we've covered. We talked about the causes of memory loss. We talked about the symptoms and how they're different from normal age-related changes. We talked through risk factors, screening, diagnosis, what the progression of the disease might look like, how to manage these symptoms effectively, and some important things to be thinking ahead for the future. So I thank you sincerely for participating and for your time. I do have a short survey. I'm going to, in the chat box here, I am going to include a link to a very brief online survey. I would love your feedback on this program. It is anonymous. I won't know. I won't know who you are. We'd love to get your feedback on the program and other topics that you would like to see. If you would like to request that PDF of these slides, you are welcome to them. But because we're not collecting your information, I'll need you to reach out and let us know. Send me an email at education@alzsd.org. And then I just wanted to make sure that you know we've got a few additional online education programs coming. Tomorrow afternoon, we will be offering a class on preparing for the late stage of the disease. And then the week after, we have a program called Living with Memory Loss for people with a new diagnosis of dementia or care partners, sort of thinking through all of these strategies that I was talking about briefly. And then on Tuesday, April 7th, we'll be doing one of our core caregiving classes called Communication Skills, learning those techniques of validation and redirection when you are caring for a person who's living with dementia. So I am right now, if you look in the chat window, I am sending out that link to that brief survey. Would love your feedback. If you've got any more questions for me, please feel free. I'm gonna stay on the line here till 5:30. If you have any more questions, I'm happy to take them. Otherwise, I thank you again for attending, for joining us, for your really great questions. I had some really good ones. And please just stay in touch with us and let us know how we can help.